very unfortunate. But Mr. Speaker, when we say no bed in the hospital, what actually do we mean? A no bed could mean that there is no physical bed at the emergency. It could also mean that there is no blood if the managers anticipate that that patient will need blood, and so they want the person to go elsewhere. It could mean there is no a particular skill. For instance, an anesthetist is not there, and they think that that patient will require surgery. It could mean there is no theater space. It could mean there is no oxygen in this hospital. There is no ICU bed, but we think that this patient needs ICU care. It could mean there is no stroke bed, and therefore we are telling you no bed because you have a stroke. There is no doctor at this moment, so there is no bed. Mr. Speaker, but the most disappointing part is that no bed could simply mean that the staff are not willing to work. And that is the very, very sad part. This no bed could mean that a shift is about to end and someone is not willing to admit a new patient and do all the documentation, so turn the patient away. No bed could mean that the doctor is afraid to work or is tired and feels that if he touch that patient and the patient pass away, duty of care is established legally because he has touched the patient. So see no evil. I have not touched that patient, so you cannot blame me for it. But is it really right if a patient dies in the precinct of a hospital, at the entrance of the emergency, wait there for 30 minutes, 45 minutes, and you say because you've not seen that patient, no duty of care is established? The legal brains will have to help us out. Mr. Speaker, the causes of no bed in this country has been established by previous committees under the former health minister, Honorable Kweku Agyeman-Menu, and I worked on that committee in my former capacity as General Secretary of the Medical Association. We all contributed to it. But
thank you for staying with us. You'd agree with me that until yesterday in Parliament, we definitely would all of us reduced no bed to a physical interpretation that there is no physical bed in our hospitals. Until yesterday, Professor Titus Beyuo put a deeper meaning and interpretation to the no bed syndrome. He is MP Lambussie, also board chair for Korle-Bu Teaching Hospital, and definitely former general secretary for the Ghana Medical Association. And so you understand why he is the most authority to speak about this. Honorable Prof. Well, I don't know why we've been addressing you as doc all this. We're so hanged over on, and also hooked to the title doctor. I hope you're well. Happy New Year. It's my first time engaging with you.
Happy New Year.
It's not so much of a happy one for you. For a board chair, right?
Yeah. It's a difficult time, especially considering what has happened to the nation. And I dare say that the conscience of the nation has been pricked once again by what could be a very preventable death. We've lost somebody who could have contributed a lot to this nation. And our focus then will be, how do we make sure another person like this never loses their life or lose their life in a similar situation. So it's a very sad time for us and a very difficult time.
We'll get to the details of the presentation you made in Parliament yesterday. But of course, I like to think you have privileged information. I know that you say Korle-Bu has started or initiated some investigation to the matter. But for you as a person, what more have you been gathering as a medical doctor for yourself to satisfy your curiosity and also for the position that you hold?
So unfortunately, I'm unable to say much because of the position I occupy as a board chairman of the hospital. These matters eventually are brought to us. The board has been briefed about what happened and the decisions management took, such as the interdiction of these staff. The board endorsed it, and we think that is the right step to take to get those people out of the space so that thorough investigations can take place. And I particularly endorse that move because I participated in a very intimate way or integral way the very first time something like this happened to the 70-year-old man in 2018. I was then Assistant General Secretary of the Medical Association. There were no interdictions, there were no punishment, and this man had been to 7 different hospitals and eventually died in his vehicle, you know, and learning from those lessons and the recommendations that were made therein, that we realized that look like they have not been implemented, and many of those things, some appear to be contributing to what has happened in this instance. We felt that we needed to take some action. That's why we endorsed their decision that yes, they should interdict them, and let's go into it. Interdiction does not imply culpability. But if the disciplinary procedures come out and it shows that, yes, people were culpable, then definitely people have to be punished.
Now, between 2018 and now, I like to think that many of such cases may have happened, except that they don't make its way to the public conversation. And I won't put you in that situation to want to explain to us how. But from the time you sat on the committee, well, not maybe sitting on the committee, but contributing to the recommendations, and 8 years today, does it surprise you that we're recording another of such death?
It doesn't surprise me because, you see, things don't work in vacuum. There have been consistent lack of investment, significant investment in where it matters most as far as healthcare is concerned. There have been definitely some improvements since 2018, but it has not gotten to the level where it should be. So, for instance, one of the things that came out is a concept of triaging, where when patients arrive at the emergency, they need to be triaged and color-coded to alert everybody in the space how urgent those patients need to receive care. So, in the instance of 2018, the man was actually triaged in one facility, color-coded, and given his triage form to move around with it, which doesn't make sense. It defies all logic. And so, if you look at the current situation we are dealing with, he was not even triaged at all. So, I mean, that's why I say I'm not too surprised, because one would have expected that in terms of our investment, we would have had more capacity at the emergency settings. Bigger hospitals should have proper emergency setup. One should have expected that we have a proper referral system. In these days of IT, electronic medical records, AI, we should have an integrated bed management model. And all this have not happened. So to the extent that if you don't do something different, you can't expect a different results.
You classify the problem into 3 areas: structural, latitudinal, and functional. We'll get to that. But I'll still stay with you on the triage bit, where I see that you say, Korle-Bu, you're investigating the matter. But as a member of parliament, of course, I've seen that the speaker as well says that it should be referred to a committee, and then you also investigate. Where will this particular committee start from? Will they start from Korle-Bu, or they'll wait for the findings that the committee at Korle-Bu level will present, and then you pick it up from there? Let me situate the question better. They are asking if this patient traveled from one facility to the other, all the way to the most referral point in Ghana. The investigation, where should it start from?
So yesterday, the speaker gave a very apt referral. There are about 2 things happening now. It's not, Korle-Bu is taking actions on its own to make sure that we can have our institutional measures. But there's a national picture. The Minister for Health is also disgusted at what has happened and has set up a committee led by a former Director General of the Health Service, that's Professor Beyuo, and then a very experienced emergency physician, a nurse, and some people to go into it across the entire span. So Speaker directed that his committee should get the report of these 2 committees. The one from the Minister for Health, that is for the entire spectrum, whatever happened from the man's pickup, the role the ambulance played, the 2 other hospitals they went to, the role Korle-Bu played. All of that is being taken care of by the committee set by the minister. Korle-Bu as an institution is also doing its own, because sadly, this man passed away in our hospital, at our emergency. Information available to us suggests that for a period, the man was at the emergency, and as I mentioned, was not even triaged, which is the basic that would tell us the urgency with which the man needs care. To the extent that I can't give further detail, but we definitely need to do something, because if we don't, it means that today, if another person gets to Korle-Bu, a similar thing will happen. But as of today, I can confidently say that the administrative measures we have put in Korle-Bu now, I cannot foresee that someone will get there with an emergency and be turned away.
Okay, that's quite refreshing to hear.
Yes.
For some of us who have had bad experiences in Korle-Bu.
Yeah.
Let's talk about the way you have segmented the situation. You say structural, you say functional.
Yeah.
I see that in the functional as well, you put attitudinal in there. So we can treat it separately or put it in the functional. In all of these three, which one is the most cancerous one in our health sector?
It's very difficult to separate because they are interrelated. So it's very difficult to select one. But definitely attitude plays a significant role. But it's very difficult to take it out of the system. So for instance, I gave some data yesterday that if you take the World Health Recommendation, the number of beds hospital beds you should have in a country should be about 2 to 5 hospital beds per 1,000 of the population. Ghana is currently doing about 0.9. And not up to 1 bed per 1,000 people in the population. Now, we are also not having an efficient bed management system to ensure that even the little we have, we can use it well. And I cited an example yesterday. Since my appointment by His Excellency through the Minister as board chairman of Korle-Bu, colleague MPs call me when someone is trying to get access to Korle-Bu. They will call Korle-Bu, they will say there's no bed. The doctors will call, there's no bed. But when I call Korle-Bu, there's a bed. Why? And I asked them yesterday, if I am the one needing this care, who will call on my behalf?
Yeah.
We must have a system that you don't need to call an individual or need to know someone to assess an emergency. So that's where the systemic thing I'm talking about, ensuring the efficient use of these beds come in. So if you go elsewhere, we have what we call emergency command centers, a national emergency command center, and in major hospitals like Korle-Bu, you have a bed command center. They have a dashboard. They are able to tell real-time bed occupancy, the type of beds available, because there are different types of hospital beds. If you take Korle-Bu, that offers the full spectrum of healthcare, you can have the normal hospital bed at the emergency. In the emergency, you can have beds linked to oxygen. You can have beds linked to intensive monitoring, continuous monitoring for patients who need that kind of monitoring. You can have stroke beds in stroke wards. You can have beds in the ICU that must be linked to a ventilator. So when you say there is no bed, which kind of bed are you referring to? And all this in very well-established systems are monitored real time on an electronic monitoring system. So the command center can tell, so that it's not left to an individual's discretion. And I did mention, that's where I said they are linked. So if you have not put in the structures to track the attitude of person, Ghanaian health workers are not lazier or more lazy than health workers in the US or anywhere else. But there are systems to make sure that if you are employed to work for 8 hours, you work for 8 hours.
Okay.
So you will not go to the emergency in a major hospital and find people using their personal phones talking there. That shouldn't happen.
Okay. So if I understand, for the structural, and we're using the case in points bed, physical bed.
Yes.
If for example, we were staying to the WHO requirements, 2 to 5 bed per 1,000 in a population, will we still need the management of such a command center? Will we still need that?
We definitely do.
Even for that method?
We definitely do.
Okay, so how robust do we need that kind of center to then manage our 0.9?
Exactly. So that's what I'm saying, that even when we have less, then the need for the management is even more.
Okay.
Reason is that someone could be lying on the hospital bed just because the person has not paid their bill. They are not ill anymore, but they are lying on the bed. And that bed is not available for someone who critically needs it. Someone is lying on a bed at the emergency because they are waiting for a lab results. The person doesn't need any care at that emergency. Could have moved to a ward to make that bed available. So somebody who needs that bed critically is denied because another person who is apparently well now is lying on it. But if we have that system that tracks, that tells, we have said 48 hours, no one should stay in the emergency more than 48 hours. By 48 hours, we should be able to triage you, take care of you, provide the basic things, and move you to the place that you need final care.
Okay.
So a system is telling us that Madam XYZ entered this ward at 9:05 today. By 9:05 Friday morning, somebody should be questioning, why is he still here? Somebody should be answering a question.
Okay.
Because that person is denying other people access to that bed.
Okay.
And if it's not for critical reasons, she should be moved. So when you are having fewer beds, you should have an efficient management system that allows you to use those beds wisely.
What's the role of the lower or the smaller hospitals in other regions and districts? The decisions they take, or the actions or inactions, how will it contribute to the success of this command center? Excellent.
They will be the greatest beneficiaries of this center. And I tell you this, private hospitals, smaller hospitals, sometimes they are frustrated. They are at their wits' end. You have a patient, you have gotten to the limit of your capacity. You cannot care for that patient beyond where you've gotten to. You want that patient to move to a bigger hospital. You call the ambulance to come and pick the patient. The ambulance will ask you, where are they sending the patient to? You must confirm a location that is willing to accept that patient. Why should the responsibility be on me, who has money to a point and know that I cannot, my skill, my training, my capacity will not allow me to continue with your care? Why should that responsibility be on me to call around 7 hospitals, finding who is willing to accept my patients? If we have a system, a dashboard, that is able to categorize, okay, if it's cardiology, there's a cardiologist at UGMC, there's a cardiologist at the Bank Hospital, there's a cardiologist at 37, there's none at Police Hospital. AI can easily do this on an app for us. So when I put my patient details in it, it should be able to tell me facilities that can accept that patient and tell me the bed availability in these facilities and tell me which one is closest to me. Okay, this patient can travel 30 minutes. This one can do 2 hours. We can go this way. This is not rocket science. It's been done elsewhere.
Well, on the face of it, what do you think? Do you think that it is the structural problem that has given birth to the attitudinal problem, or the attitudinal problem has been a constant one that is widening the structural problem?
The structural problem is contributing to the attitudinal problem, because even people who are well-intended are struggling to function because the structure is not there.
Okay.
But the attitudinal problem is made to grow because the defect in the structural problem means that you can't pick out the bad nuts to deal with them. Because you cannot monitor what is happening real time.
Yeah.
You cannot tell when someone is just tired and doesn't want to work. Have you noticed that most of these things happen in the dead of the night?
Yeah.
The 70-year-old, it wasn't in the afternoon, where managers have gone home, where supervisors may not be there, where the night supervisor may be there but at a different location. Why? Why is that these things happen at that critical time? So that is where I'm saying that if you have a system that allows you to track human behavior, people know that I'm being monitored. My KPI is that this patient should be when the patient arrives here within 10 minutes, I should have done A, B, C. And the time of arriving of the patient has been time-stamped on the system. If in 10 minutes I've not been able to do A, B, C, a supervisor will know and ask me a question. You behave well.
Tell me, is Korle-Bu genuinely overwhelmed, or it's just a perception?
No, I don't think Korle-Bu is our biggest hospital. There's no doubt about that. We have a very huge workforce, but consistently our investment in Korle-Bu to put it where we want it to be over the years has not been up to scratch. I read the history of Korle-Bu. In 1923, when Korle-Bu was being opened for the first time, what Korle-Bu could do, even at that time, the automated system that they could count the number of patients coming to the OPD, today we don't have all of that. Some of the structures in Korle-Bu now were built at that time and are still there. The population has increased exponentially and the consistent investment is not in. So that makes the situation difficult. But thankfully, Korle-Bu is being relieved a bit by the presence of other bigger facilities in the city. So you can find Police Hospital that is coming up Rich Hospital, the Greater Accra Regional Hospital, now a very big facility, 420 bed. UGMC is coming in. So all these facilities can mop up the pressure. But how would they mop up the pressure if there's no central system monitoring what is happening everywhere?
Okay. When we champion the no bed on the face of it, the physical,
yes,
no physical bed,
yeah,
I'm very fascinated by the other definitions that you've been teaching us as a country yesterday and even this morning. When you say that no bed could mean there's no blood, when we anticipate that this person will need blood.
Yes.
After you have solved this very physical part, now we have beds.
Yes.
But there are different legs of it.
Yes.
ICU equipment that you will need.
Yes.
No blood.
Yes.
Would you ever have an end to the no bed syndrome at all?
Good. So on that score, I want to commend the current Minister of Health, the Honorable Kwabena Minta-Kando. He's been very passionate about this, and I do believe it's also with the direction of His Excellency the President that we should find a solution to this once and for all. And they started it just about the time we changed over from light wave to this Ghana Health Information Management System. Right from that time, the Honorable Minister had tasked a group that I'm part of to work on to bring a solution to this. That's why I'm saying this has taken us, it's a very painful blow, because it's making the interpretation to look like everything that is happening is just because of what has happened this week. But people have been working in the background to find a comprehensive solution. The vision of the Minister for Health, if it's implemented and backed by funds, yesterday I called on Parliament to support him. We will get to that point where we can have a solution. Because in this day of AI, that is the only way we can solve this.
What will a real solution look like?
So a real solution is going to be that we should have an emergency command center.
Okay.
An emergency command center that in Ghana here, anybody, whether a patient, a doctor, a bystander, sees a health emergency, you can call that command center. If you call an ambulance, the ambulance is linked to that command center. So that command center, all beds in this country are then marked, barcoded. They just scan and they can tell the availability of the bed. And people are feeding information in on the hour. People's actions are tracked in the hospital on the hour. This command center sees the whole country, all our referral points in a snapshot. Then they can distribute the patients. So when you call in, you say you found a middle-aged woman lying unconscious. Is she bleeding? They say, yes, the person is bleeding. Location, you mentioned, it's at Joy FM on your frontage.
Yeah.
They would say, okay, 30-year-old female, there's bleeding. They will put that information in. It will be generated immediately, facilities that can cater for that person.
Okay, so they don't have to always come to Korle-Bu or the hospital they think
that it is
need.
Okay. If this thing happened in Circle here, this gentleman was knocked down in Circle here, you pick up the person. The ambulance, as of today, when you call the ambulance, they will always want to find out where can they receive the patient. That would be a thing of the past if the plan and vision of the minister is able to materialize. Because when ambulance people pick that person and they input this information, immediately it will appear on their dashboard. The closest hospitals that have space and that have capacity to manage this. Currently, the ambulance is required to call the hospital in advance and give what we call pre-arrival information so that the hospital will prepare for the patient. Okay. Now, that calling...
It's the sole responsibility of the ambulance
when they pick up a patient.
When they pick up the person.
A person.
Okay.
Similarly, if the person is moved from a less hospital, the hospital is mandated to call the referring center and tell them, we are bringing you a patient who needs this and that. Okay. So that they will prepare before the person arrives. Okay. All that will now be transmitted electronically.
What would you say to the ambulance service that says that nearly half of the ambulances are grounded? It also feeds into the bigger problem.
So that's why I talked about lack of consistent investment. We don't put our efforts where we need results from.
But health conversations and policies are quite political, are they not?
But they shouldn't be.
What would you do for sustainability and continuity?
They shouldn't be. So the ambulance service, for instance, I called yesterday, we have to review their act, we have to look at their SOPs, even the training of the paramedics in there, what they are capable of doing. Different types of ambulances needed. Currently, it's one size fits all. But in proper functioning system, minor procedures can be performed, even minor surgeries can be performed in ambulances.
Yeah.
Based on the type of ambulance that is available. We shouldn't just buy a huge quantity of ambulance and distribute them nationwide and everybody feel happy that I have one ambulance in my constituency. That is giving false hope if that ambulance cannot do much.
In all of this...
And they are only scooping and running.
Yeah.
They should be able to do something.
Prof, in all of this, what do you say to health practitioners or health service delivery persons who say that the government should not scapegoat them?
Well, I don't think it's scapegoating. The government is not scapegoating. But you see, to the extent that I have been a general secretary of the association before, I've served the association several years, and I will be the last person to punish people unfairly. But if we also cover people's misbehavior in the under the cloak of unionism, then people will find shelter and misbehave more. Where people have really gone below the standard expected of them, punishment must be exacted.
How far are you willing to go to see an end to this? How far are you willing to go to give respite to our friend who's lost his life because of the system?
So the first thing is that
the family of that friend.
Not much can be done that can really assuage their pain. No amount of intervention can bring him back. But what we can do that can help their family, that can help everybody else, is to see a turnaround of the system to assure that family that should any of them have this problem, they will not suffer the same fate. And that's how far we are willing to go with the systemic changes, but also making sure that the attitudinal bit is corrected. If people are found to be negligent or derelict of their duty, we are willing to go the full haul as the law permits. But we must first establish that people have done something wrong, and then we'll go ahead.
Finally, before I let you go, I'll take you back to the first thing that you said, that today, as we speak, if you visit Korle-Bu, you're not likely to hear there's no bed.
Yes.
This is an assurance.
Yes.
What does this look? Would it be at the emergency front where we get there, or before you even get to the facility, you have that confidence that you're showing us today that there'll be nothing like that?
So there's an institutional arrangement in Korle-Bu where a firm directive has been given that absolutely no patient should be turned away at the emergency. And if that kind of decision has to be made, it has to be made at the highest level in the hospital. So the head of department or that unit, the consultant on duty must be involved. So a frontline staff will not have the capacity to tell somebody we don't have a bed. And the reason is that we believe firmly that whenever we say there's no bed, as I've articulated to you, when someone higher call, there's usually a bed.
Yeah.
So what is it? It means that when we make the right calls, we can make internal arrangements to provide care for the people. Even if we cannot continue with the care, let's resuscitate, let's maintain life, and then find a better place that a person can get to continue with their care. And that is a firm assurance that we are trying to give to people. But we would also add that this can be properly implemented if the necessary financial support and investments are given. Let me call on corporate Ghana, let me call on everybody. You can support the health system. You can support the health system. People can visit Korle-Bu under all this emergency that we find ourselves in and decide to give us more beds in some areas, renovate some buildings for us, put up whole blocks so that we name them after you and your family. And then that can expand our capacity to be able to provide this care.
Prof, I think that the conversation has just started. I definitely will call on you for us to continue. But thank you for making time for us on the show.
Thank you. Most welcome.
Professor Titus Beyuo is MP for Lambussie and board chair for the Korle-Bu Teaching Hospital, trying to find some real solutions for that problem, no bed syndrome, and he is also former General Secretary, Ghana Medical Association. My name is Emefa Kusiadeti.